here at United Solutions, and we have some new guidelines that have started for 2021. I wanted to really specify that these are only for E&M codes 99202 through 99215. It does not affect your hospital, behavioral health, any of those charges. It's just these E&M codes. It doesn't affect your well visits, anything like that. So just wanted to really specify that this is really all it takes effect for. I wanted to go to the next slide with your impact, what this is really going to impact. It's really focusing more on taking care of your patients and not documenting. And the only pertinent information now needs to be documented. You no longer have to have 3 bullet points to get a 99214 or do all your social, family history, social history, those types of information every time the patient comes in. It's supposed to overall improve your patient care and reduce administrative burdens on your side. And so instead of everything being audited, the only thing that will be deciding your E&M code now is your medical decision making. And so you're establishing diagnosis, assessing its status, and selecting a management option. The MDM consists of 3 elements. I don't want to read all this, but it's the number and complexity of conditions addressed, the amount and complexity if you have to review data, and then the risk or complications, morbidity and mortality. And so your current guidelines right now are based on your 3 components, which is your history exam and medical decision making. And then if you did time, it was only used when counseling or coordination of care was more than 50% of the visit. So what you have now is the code 99201 has been deleted, which very few providers ever use the 99201, simply because it was just very rarely used. Time now can be used to code the visit. However, the visit does still require a face-to-face encounter. And the MDM is the only used to decide the level of your E&M code. With that said, although the HPI review systems, your past family social history and exam will not be scored or used to consider these E&M codes, it's still necessary to support the medical necessity of the visit. And so basically, you will now go back to documenting what you need to support or what you need to diagnose that patient that day. With that said, also, please make sure that with the providers being or your clinic being an FQHC, that you still have to document the required elements for your FQHC and to obtain your HEDIS score. So that you cannot forget when you're doing your documentation. So if you have to do a fall risk, you still have to do the fall risk. It doesn't count toward anything, but you still have to do it. Different things for your diabetes patients, for your HEDIS scores, you still have to do those. Although it doesn't count, you still have to do it. And so we're down to the medical decision-making part of it. And this is basically what is going to determine whether you have a 99213, a 214, 215, 212, or a new patient. If you'll notice on this screen, before, if you remember, your 99202 was comparable to a 99213. And your documentation for 99203 was comparable to a documentation for 99214. They've gone back and they fixed that now. So it is strictly a 99202 and a 99212, or considered straightforward. And I have listed on there the times that are required if you wanted to use the time element. but you have to be careful if you're going to use that time element, because at the end of the day, you can't have 13 hours worth of work and you were only there 8. So be very conscious of that. But I could see providers using that if you're seeing patients for anxiety, some type of behavioral health type visit. If you're a provider, there's probably not going to be much documentation that's going to be required. Most of that may be talking. So this may be where the time would be a beneficial to you. And so this is now, everything is pretty comparable together. Just remember that there has to be 2 of the 3 elements. If you ever saw my old score sheet, if you ever was privy to have that, there was 3 different areas. It was the number of diagnosis that you had. It was the number of medical records, or if you ordered labs, and then your medical decision making, how many diagnoses that you had. That's pretty much what all I have to look at now. And so you have to have 2 of the 3 elements. So it's still back to, you have to have 2 of the 3. And so I can drop 1, but then the lower of the 2. So you would have had a 99213 and a 99214 at one point, but it's still going to come down to a 99213. Is that making any sense? Do y'all have any questions, or let's go through the rest of it, and then I actually have some exercises that we can look at, and then hopefully then that will kind of put this all together and kind of make a little more sense for you. And also we can kind of go into some questions and answers. And because in your patient management, the complexity and risk, here is what it boils down to. If you have one self-limited or a minor problem and the minimal risk of morbidity, then you have a 99202 if it's a new patient, and a 99212 if it is an established patient. The low risk, these kind of stayed the same as it was before. The 2 or more self-limited or minor problems, 1 chronic stable illness, or an acute uncomplicated illness or injury, and the low risk of morbidity, these actually stayed the same. If we go down to the 99214, this actually pretty much stayed the same. It was 1 or more chronic illness with an exacerbation, or 2 or more chronic stable illnesses, an undiagnosed new problem with uncertain prognosis, an acute illness with systemic symptoms, or 1 acute complicated injury. And you could add an acute complicated injury or illness. The morbidity, it's a moderate risk of morbidity. And these are examples. They're talking about that you could add in prescription management, which has always been under this 99214. But if you remember, if you had 2 chronic condition patients, then, but it always tied to that you only had 2 diagnoses, it always pulled this down to a 99213. But you had this, well, now everything pulls it to a 99214. So if you've got 2 patient that has hypertension, the patient that has diabetes, you've addressed both of those problems, you've prescribed their medication, you now have a 99214 very easily. Where the differences come in now is the 215. Before, this kind of was only, you very rarely could use it. But now there is time, if you've got a patient with a chronic illness with a severe exacerbation, and these are examples again, decision regarding hospitalization. Maybe you're talking to this patient and trying to decide if they need to go to the hospital or not. Now you have a 215. Before it was almost, patient had to be almost on their deathbed to get a 215. But now you can get that with decision for hospitalization or drug therapy, which requires intense monitoring for toxicity. You know, it's a threat to life or bodily function. So if you've got a patient that you are discussing hospitalization on, now you can get a 215 very easily for that. Do I have any questions so far?
Nope. I don't.
No questions? Okay. Well, let's go down. I've got a few examples here that I'm hoping that maybe this will bring it all together for you. Realize though that I am just done. I did not include. Yes.
I was going to show you where their questions were.
Okay.
If they had, like some of them are typing them, but I can't see it on here. I'll just keep up with the questions.
Okay. Okay. Brittany's going to keep up with the questions, and then we'll do them here in a minute. Because I don't see them. I guess maybe I wonder if I could minimize my screen. I bet then I could probably see it. We have a new patient. We see the new NP. Now remember, this is just kind of the end part of it. Okay, it's not the exam in there, you know, all of that's done. We're just not looking at that part of it. We're just basically looking at the HPI and the ending diagnosis. Okay, so we have a sore throat. You know, this is a very good HPI. You have everything you need to probably diagnose that patient, you know, paint a picture. Do I have a question? Okay. This is a good HPI here. You've painted a picture of what you need. You've asked all the questions of what you need to take care of, basically, before you start seeing the patient. You know, no longer do you have to ask them, you know, do they, you know, what kind of questions would you, you know, you don't have to do a family history. This patient's coming in for sore throat. Do you really have to do a family history? Do you, you know, you might do a past history to see what medications they're on. Of course, this is a new patient, so you may have more that you need to do. But I can tell by this, it's a black Ford Fusion that's telling me this is a patient that's probably being seen in the parking lot. And so they're probably doing the very minimal that they need to take care of this patient. You're probably not doing a full history. You have a lab that was negative. And so here down here is the notes of what you told this patient to be. And I'm going to tell you the next slide shows the answers, but I'm going to tell you I coded it as not a new patient. So this one, because it is an acute pharyngitis, I would have coded that, or I would have approved or looked at and said a 99203 because you have an acute pharyngitis and it's something acute with an uncomplicated illness with a low risk. Since there was no prescriptions given, it's just a matter of you're giving them just reassurance and what to do to call back if they have any symptoms that are worsening. Just remember that, and I'm going to stress to you that it's going to be now more important than ever to diagnose to the highest specificity.
Verlin,
Yes.
I hate to interrupt. Are you able to make the screen full screen so that they're able to see it a little bit more? They're asking for full screen.
I've got Brittany in here looking.
Okay. At the bottom down here, the bottom right where the little, yeah, thank you.
Is that better?
I believe so.
Nope.
Yes. Is that better for everyone? Huh?
Because it's full. Is that full screen?
Yeah.
Um, Maybe if you hit the display settings and change it from the like presenter view to the to slideshow.
Is that better?
I think.
Yes, that is much better. Thank you.
Better? Okay. 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 So here this is the one we just were talking about. And again, I wanted to talk about the specificity for the acute, because let's go on to the next slide and then we can kind of talk about it a little bit more. This one, a 6-year-old female patient with the mother on a video. This is a TMV visit. Mother states, you can kind of read all through it. Again, this is a very good HPI, because no longer do you have to do an HPI and a review of systems. I know y'all use ECW also, and if you use a template, you've got your HPI, and then normally your review of systems is a total big section at the bottom. No longer do you have to put them both places. You can do it all right here. Okay, this one has a viral gastroenteritis, supportive care, encourage PO intake, hydration. Can someone speak out and tell me maybe what you think this one should be? Or what you would code it as? And I'll tell you, I would have done a 99212 because it's a minor problem with a minimal risk. And again, this is where it came in very specific. If this would have been an acute one, maybe patient was on the verge of dehydration. You know, if that would have been documented there, then possibly it could have gone to a 99213. But with this information right here, I would do a 212. Okay. This one, we have a fever with an ear pain. A fever for 3 days, has fever, and you know, it didn't do a whole lot of, they didn't put a whole lot of review of systems up here, because I can tell you I cut it off for the review of systems. But again, if you want to do it this way, that's fine. And of course, in between all of this is going to be your exam. But again, I know pediatricians, you're probably going to still do pretty much an 8-point exam, because even if the patient had fever and complains of an earache, you know, this one's probably an older patient, so they can tell you more. But if you had a younger child that's maybe not able to complain they have an earache, you know, just because you check their ears and see an ear infection, I still would think that you're going to do a further investigation to listen to their heart, their lungs, checking their throat, to do a little more of an extensive, just to make sure that that's not your only issue. But this one was, and so they did a recurrent acute. It's a non-recurrent acute. And so we've got a very specific diagnosis. Okay. But it's one acute illness. And then we've got some antibiotics given. Okay, so if we go back to this screen, we've got one acute uncomplicated illness, but yet we've got prescription management. So we've got a 99214 and a 99213. So again, you're going to take the lower of the two and you're going to do your 213. Does that make sense?
Yes.
Okay. Okay, because it was one acute uncomplicated illness. Of course, we had with the moderate risk of prescription management, but again, we take the lower of the two. So then let's go to this one, because this one is be a little more adult. 35-year-old female established patient. So we know we've got an established patient. Presents to your PCP for follow-up of stable type 2 diabetes mellitus. The physician performs a medical appropriate history. We didn't get all that. And physical, we didn't get all that. And refills medications and determines the meeting to meet a low level of MDM. So this provider already told us that it meets a low MDM. So we've got one stable chronic illness. And the provider refilled the medication. So we've got prescription management that pulls in a 99213. Because again, we have a 99213, but we've got a moderate 214. So it's those two. And I really did not go into a whole lot when I was telling you the two of the three, because the middle section, again, is a lot of, did you review previous records? Did you review, did you review labs before you went in to see the patient? All of those will count towards this, but again, it's almost like it was in the past. It's never going to be higher than one of these unless you really do 4 or 5 things, like review labs, review old medical records, talk to a patient's previous provider, or have all these labs and medical records, and then talk to a specialist. All of those would up one of the other codes, but more than likely it's not, which is why I didn't even really add it to this slide presentation, because it's out there, but it really doesn't make a whole, it's not going to make a difference. It's still going to be between your diagnosis and your risk of morbidity and your risk management. So this one, let's go a little bit higher. Okay, this one, the general says needs refill. It talks about some different things there. What I would like to see more is where it just says up here, med management needs refills. Needs refills on what? I see a lot of, from y'all's charts, I see a lot of 3-month follow-up. 3-month follow-up on what? What are you following up on? Now is your time to get it all right up here. What are you seeing this patient for? What information do you need necessary to let an auditor know why you're seeing this patient today? I see a lot of this needs refills. As an auditor, I wouldn't know what refills you were needing. And honestly, unless you looked further into the file, we can see it all here. But, is the patient compliant with their medications? Are they having any issues with their medications? This is where you can extend on that just a little bit more. And that would be helpful to, as I've always said, paint a picture of what that patient is there for. But again, you want to paint that picture of only what is necessary to see that patient that day. And so, as you can tell, this one has a long list of problems, refilled a whole lot of medication. It looks like there's no, we're going to say that the patient's having no problems. Everything is stable, because it looks like everything was just refilled. Nothing was increased. So this one would be a 99214, because you've got 2 or more stable chronic illnesses with a moderate risk due to the prescription management. Now you've got 2 or more. You've got 2 or more stable chronic illnesses, and this kind of falls under a moderate risk of morbidity, because you've got some prescription management in there. So let's go back to, let's do another one. I think I have one more after this, and then we'll start with the questions. This one is a 60-year-old this is a new patient, and I'm going to tell you again, I didn't do it right. A new patient with a history of hypertension and diabetes. Kind of the same thing, brought in patient, this is a new patient. The physician reviewed the medication brought in from the patient from a previous provider. We told them to bring in their bottles, did an appropriate history and physical. Provider ordered a blood sugar level and a A1C, hemoglobin A1C, and both were found to be within normal range. Provider refilled current medications for the patient. We've got a new patient, 2 chronic problems. Here the provider told me they reviewed the medication from the previous provider. This is where I was talking about you could get 1 point for this, but it's really not going to make a difference. So this one again would be, now I did it wrong. I told it a 214. It sure really is a 204 because it's telling me here it was a new patient. So if you would have done a 214, I would have probably come back and said, no, it needed to be a 204 because you've got 2 stable chronic problems, prescription management. The next one is going to be a good example for, I'm going to tell you, a 215. 70-year-old, this is an established patient with a history of COPD. Only one chronic condition that they're addressing today. Patient is currently having difficulty breathing and coughing. Patient state started last night when laying down, but it was able to rest in a recliner, but it's worsening now. Has no fever. They do appropriate history and physical and determine the patient is having a chronic COPD illness with severe exacerbation. Maybe they're talking about hospitalization. Maybe they're doing more. They would do a breathing machine, a breathing, treatment there in the office. To me, you've got a chronic severe exacerbation with a high risk for patient management and morbidity. Just maybe you're deciding on decision for hospital. Let's go back to the example. You might have an acute, possessing a threat to life because she's having difficulty breathing. Maybe you're adding some drug therapy that requires some monitoring for toxicity. Right here, you've got very easily a 215. So this is where now, again, as I stated before, you're going to be able to do some 215s, not just some 214s, because this is kind of where you got stuck at. Now you can do a 215. And so I want you to be able to feel comfortable coding a 215 if you've got some of these chronic illnesses with severe exacerbation. Now, if you've got this with the severe exacerbation and maybe all you do is do a prescription management or that, then that's going to throw it to a 214. But maybe you're doing more here or you're doing more here. That would keep it as a 99215. Or maybe this patient was, and the time is maybe you spent a good 60 minutes with this patient. Well, if you did that in time-wise, if you spent 60 minutes with this patient, you've got a 99215 or a 205 if it's a new patient, because you only need 40 to 54 minutes with this and maybe that's where you can count the time. Now, remember, the time is only you as a provider. It's not your medical assistant time, but it can be, maybe you spent 20 minutes with them. The nurse went in and did a breathing treatment. And so then you went back and spent another 20 minutes with them. Then you can use the time. You can say, I spent 40 minutes with this patient. And let it go. You might use that as a time. So just remember that your times are available also, because again, you might have a patient that's coming in that's just having maybe a low anxiety attack, or maybe anxiety, that you end up spending 39 minutes with them or 40 minutes with them because they're crying on your shoulder, or they just needed somebody to talk to that day. That's where times can come in and be very helpful to you. So always remember those are still available. Okay. And this is my old one. I just put it on there just in case somebody had any questions then wanted to look at it. Okay, so I can figure out how I can see questions, and then we can kind of go with questions. Brittany, do you want to read them to me?
I've got a quick question. So one situation that I've been seeing, so some kids come in, they've been exposed to COVID, but need a COVID test, like after so long after the exposure, to be able to come out of quarantine. So in that situation, these kids come in typically asymptomatic and then typically just doing a COVID swab and that type of thing. Do you think, like, I'm guessing that would be a 212, or?
If that's really what you're doing, okay. If that's really what you're doing, and there's really no issues,
Yeah.
then yes, I would think that is a 212.
Okay.
Are you doing the rapid one, or are you doing the one that needs to come back?
The rapid one.
Okay. So if you're doing the rapid one and it's negative, then yes, you've got a 212. But if it's positive, then you're going to do a little more treatment. You now probably have bumped yourself up to a 213.
Okay.
And I saw a lot of full screens, sorry. Okay. So I'm looking, I don't really see any questions. Is there any questions? And I know that probably once you get into it, there's probably going to be a few more questions. But honestly, if you just keep diagnosing and doing what you're doing, you're going to be fine. What I'm hoping, what the outcome was for this is so that you don't have to add in all the stuff that's not necessary. So hopefully this will take care of duplicating information, because you've got or something's in the HPI, and then in the review of systems you have it negative, because so much of that stuff is a template and it's coming in now, and you get busy and you forget that you need to you need to go in and change that. And so as my presenter or one of my trainers told me, she said, I call it leaving out the fluff. No longer do you have to fluff it up to see that patient. And that's exactly what it is, because again, just document what you need that day to see that patient. And hopefully it will prevent pulling over 12 diagnoses that this patient has had in their lifetime. It's not going to count if it has not been addressed in your HPI, in your exam, or somewhere in your assessment that you're refilling medications for it. It's not going to count. So you may only have one that you're really dealing with, but this patient's had 3 other issues down the road that has nothing to do with today's visit, but it pulls in as a diagnosis. They're not going to get counted.
I have a question.
Yes, sir.
Yes, so kind of related to what you were just saying, I was wondering about when you code for a new patient, it almost seems you're saying that all it needs to say is they're a new patient. So to me, the point of coding being paid more for a new patient is that's when you do add some of the fluff, like you need a past medical history, and
you're going. Yes, you're.
Is that not really required anymore?
It's going to be, as far as making a diagnosis that day. No, but do you again, the one that I showed, that was a new patient that was there for a strep throat that was in the car. Now with COVID going around, it makes things practicing a little bit different. You may not be able to get all that information today, so you can now still see that patient as a new patient. But eventually, I can see you as a internal adult medicine. You're probably going to need a lot of that information to make a firm diagnosis that day. And especially if you've got a patient with some chronic conditions, you're going to have to do some past medical history. You're going to have to do some family history. You're going to have to do a little bit of social history. Does the patient smoke? Or those types of things. You're going to have to do some, but you may not need a 10-point review of systems that day.
Right.
Again, for a new patient, you're going to need some, but you may not be able to get it specifically today, but maybe next time the patient comes in. Let's say the patient's coming in and maybe it's having an adult having a sore throat, but they've got hypertension, they've got some underlying chronic conditions. You may have to address those today to form a diagnosis. That may depend on how you treat that patient that day, what medications you give them that day. So yes, I can see as a new patient, you're going to need some of that information.
So if they weren't in the car and you didn't have that information, could you still code as a new patient?
Yes, you can still code it as a new patient.
So what I'm hearing is we still, of course, want to do a good job and do everything we need to do to take care of our patients, but that's not really a key in the coding.
It's not key for coding for a new patient. No,
Got
because
it.
the only thing I'm going to look at is your medical decision making.
All right, very good.
Okay.
Why did this change occur? I mean, but what body, instituted this common sense approach? I'd like
The
to.
AMA is one who started it. It probably started a couple of years ago. They started rewriting the guidelines for the E&M coding. The old E&M coding hasn't been changed since maybe 2010. And so they went in and said, okay, now with the EMRs, we have more access to see what is out there for that patient. And so do we need that every time we see the patient? Do we need that in every medical record? You can very easily click a button in ECW and see what the patient's medical history is. Whereas now, so they've actually gone to, AMA started it, Medicare took it over, CMS took it this year. I was really surprised, and everybody else really was too. They were really gung-ho on it at the very first of the year. And then when COVID hit, it kind of stopped. And so I was really surprised that nothing was ever said about it again until probably middle part of October. AMA and CMS comes up and says, oh yeah, we're going to go ahead and do this. And so it didn't provide a whole lot of time to get everybody oriented and trained on it. And so that's kind of why it was a real fast outcome, but very slow getting training out there, just because everything just kind of stopped when COVID hit.
All right, very good. Thank you.
You're welcome.
I have a quick question.
Yes.
So I'm a pediatrician, and a lot of what I'm hearing in different pediatric realms is because we are getting most of our history from a parent or a grandparent, or sometimes it'll be, a grandparent that brings them in, and then we also talk to a parent on the phone during the visit, that would help to increase the level. So, for example, the viral gastroenteritis case that you showed, traditionally we would code that as a 99213 because we're talking about multiple systems. We're giving lots of empiric advice about when to return. So does the fact that we're getting information from family members change anything, or would that still be a 2?
Well, you would get credit for that. And that's kind of what I was talking about when that middle section is in there. You can get credit for that, but it's only, again, like 1 point.
Okay.
And so it's really not going to make a whole lot of difference. But again, if you feel like that this was a 99213 visit, then you need to code it as a 99213. Just make sure that the documentation supports what you're talking about. If you talk to the parent on the phone, be sure to, this may be where time comes in very handy.
Yes.
Okay, because you could say you could document 10 minutes with the, seeing the patient, and then I spent 10 minutes on the phone talking to the parent because the grandparent brought the child in today. Okay, so that's 10 minutes right there. Or that's 10 minutes visiting, that's 10 minutes talking to the parent on the phone.
What if that occurs on at a different time period? So sometimes I'll have to call back the divorced parent or the granddad or whoever also wants to hear the whole saga. Does that time count in that visit too?
As long as it's in the same day, it can count.
Okay.
Okay. So they consider if it happens on January 19th, that's the same day. So you may have seen that patient at 9 o'clock that morning, but you didn't talk to dad or mom or whoever till maybe 6 o'clock that evening. As long as it's on the same day, it counts. So you would just basically, you wouldn't be able to close out that note until you finished with your conversation with mom or dad. Because let's say you spent 10 minutes examining the patient, but then you spent 20 minutes on the phone with mom, dad, whoever, and you spent 20 minutes. Well, that's 30 minutes. Well, now it's bumped it up to a 99214.
Okay, thank you. That's kind of what I was going to clarify. Yes, thank you.
Okay. Dr. Gibbs, I'm going to add into that. Just be sure that you don't have to document the time like it was 6 o'clock to whatever. It's just you can document 10 minutes on the exam and 20 minutes visiting with mom on the phone or whoever you spoke with on the phone. That's all you have to put. You don't have to put specific times. It's just that information needs to be in the medical record.
Okay, thank you.
Okay. Do we have any other questions? And did y'all receive this slide presentation? Did y'all receive it?
I don't think so.
I did not receive it.
Okay. Okay.
I didn't either.
Okay.
If you can
Well, I'll resend it out.
I
I think it was sent, but I'll resend it out so that you'll have it to kind of refer back to.
Okay.
And I might put in, I have one other little cheat sheet that I kind of made for myself that may be a little helpful. It's all on one sheet of the different times and kind of what's all in the 99212, 213, 214, 215, and especially with those times listed, that may be a little helpful for you. And I'll include that also.
Okay, thank you.
Okay. Well, if there's no other questions, if there's anything that comes up, or you think of some later, the office, they know how to get in touch with me. And so I can, I'll be glad to answer any emails that you might have, or we can do a quick phone conversation if you need to speak with me, whatever we can do to make this a smooth transition for you. I'm here to help you.
Thank you.
Okay.
Thank you, Verlin.
Thank you
And
so
I
much.
did, the meeting, like I said, it was recorded. So for those providers that did miss it, or if they want to refer back to it,
Okay.
I can also send them that as well to the
Okay.
site.
And Shanika, I will send you this PowerPoint presentation. Can you
Yes,
get it out to everybody?
I sure will. Yes,
Okay.
ma'am.
Okay. Sounds great. Thank
Okay.
y'all.
Thank you so much. I appreciate it.
Thank you.